welcome to the deep dive. Today we're tackling popliteal artery aneurysms, those bulges in the artery behind the knee.
Yeah, a really important topic, and quite common, relatively speaking.
And how we manage them has shifted quite a bit over the years. We're going to do a deep dive based on some key research today.
We are. Specifically, we're looking at a really pivotal paper from 1991 by Shortell and his group.
The 25-year surgical experience one. I've heard of it.
That's the one. It's featured in that 50 Landmark Papers book for vascular surgeons, and it really, it changed the conversation quite dramatically.
Okay, so let's set the scene. Before this 1991 paper, what was the general thing? It sounds like maybe things weren't so clear-cut.
Not at all clear-cut, no.
Yeah.
Before Shortell, the best way to handle these aneurysms was really up for debate. You had earlier studies, Gifford, Riley, Whitehouse, Anton.
Right. Some of the older foundational work.
Exactly. And they presented kind of a muddled picture, honestly. Some results suggested, surgery has risks. Maybe just watching the smaller ones, the asymptomatic ones, is safer.
Okay, that makes a certain kind of sense on the surface.
But then other data really highlighted the dangers of waiting, especially the risk of the limb if the aneurysm suddenly clotted off. That limb-threatening ischemia.
A catastrophic event, potentially.
Absolutely. Losing the leg was a very real possibility.
Yeah.
So, no firm agreement on when or even, how aggressively to jump in.
Interesting. So with all that uncertainty floating around, what were Shortell and his team really trying to nail down with their study in 91?
Well, they wanted to figure out what factors actually made a difference in how patients did after surgery for these aneurysms. Their study was a retrospective review looking back at patient records.
Okay.
They had 39 patients, and between them, 51 popliteal aneurysms that were operated on. This was between 1958 and 1990, so a good chunk of time.
Right, and they split them into groups.
Yeah, and this was key. They specifically looked at emergency repairs, 19 limbs, where the patient came in with that limb-threatening ischemia we talked about.
The urgent cases.
Versus the elective repairs, planned surgeries, which was 32 limbs. They also carefully noted the surgical techniques, the bypasses they did.
Like going around the aneurysm.
Exactly, creating a detour for the blood flow. And what they used for that detour considered the patient's own saphenous vein.
Gotcha. And what did they find right off the bat, like the initial 30-day outcomes?
So in that first month, the mortality rate was 6%, which, reflects the seriousness of major vascular surgery back then.
Mm-hmm.
But encouragingly, the patency rate, meaning the bypasses were still open and working, was really high, 94%.
That sounds good.
And the amputation rate was 6% initially.
Okay, 94% patency sounds promising, but surgery outcomes often change over time, right?
Mm-hmm.
How did things look further down the road?
They really do, and that's where it got, more complex. While saving the limb initially was very successful, 94% limb salvage. The patency, how well those bypasses stayed open, it dropped quite a bit, down to 67% after 6 years.
Wow. Okay, so a significant drop-off.
A big difference, yeah. And that gap between limb salvage and long-term patency is really critical.
And did it matter how the patient first presented? The emergency versus the planned surgery? Did that affect the long-term picture?
Hugely. That was one of the most striking findings, actually. At just 1 year, the patency rate for the limbs that came in with severe ischemia was way lower.
How much lower?
Only 69% stayed open, compared to a perfect 100% patency at 1 year in the elective group.
100%. That's a massive difference.
Massive. And think about this. All 3 amputations that occurred happened in that emergency group.
Okay.
And it was because their bypass grafts failed, they clotted off. So limb salvage overall was 84% in the emergency ischemic group versus 100% still in the elective group.
Wow. That really hammers home the point about trying to intervene before it becomes an emergency.
It absolutely does. It's a stark difference.
What about the blood flow further down the leg? The runoff, they call it. Did the quality of those downstream arteries matter?
It did, but interestingly, it mattered differently depending on the situation.
How so?
In the elective group, the ones having planned surgery having good runoff, meaning 2 or more healthy vessels below the knee for the bypass to flow into, that led to better long-term patency, especially after 3 years compared to poor runoff, just 1 or 0 vessels open.
Okay, that makes intuitive sense. Better plumbing downstream helps.
Right. But in the emergency group, the ones with the acute ischemia, the runoff quality didn't seem to make a significant difference to patency.
Huh. Any idea why?
It's likely that the The acute clot, the whole inflammatory process and damage from the ischemia itself, just overwhelmed any effect of the baseline runoff. It was a more powerful predictor in those urgent cases.
I see. The paper also mentioned something I thought was interesting, late enlargement of the aneurysm after it had been bypassed.
Yes, that was a noteworthy finding. Not the main point, but significant. In 4 patients, all of who had symptomatic aneurysms that were saccular, sort of like a side pouch bulge,
Okay.
the original aneurysm sac, which was technically excluded by the bypass, actually started growing again, significantly, 5 or more years later.
And that required more surgery.
It did. They needed further operations to deal with that late complication. It reminds us that even bypassed aneurysms sometimes need watching.
So putting all these pieces together, the better outcomes for elective, the terrible results for emergency, the runoff details, even the late enlargement was the big aha moment, the main conclusion that really, shook things up.
The big takeaway, the message that really resonated, was that elective repair should basically be offered to all patients found to have a popliteal aneurysm, assuming they were fit for surgery.
All of them, even small asymptomatic ones.
That was the implication. Shortell and the team argued that the risks of elective surgery were acceptable, and crucially, doing it electively prevented the much higher risks and the much poorer outcomes associated with waiting for that limb-threatening emergency.
So it directly challenged that older idea of just watching and waiting for some patients.
Directly. It said, no, being proactive is likely better for limb salvage. It wasn't just about this one artery either. It kind of reflected a broader shift in vascular surgery towards intervening earlier, when possible and safe, to head off worse problems later.
That feels like a really significant shift in practice philosophy. How did this paper actually change what doctors were doing day to day? Did it really alter the landscape, as the book says?
Oh, absolutely. It provided pretty strong evidence against just passively observing asymptomatic popliteal aneurysms. The default thinking really shifted towards recommending intervention.
So less watchful waiting.
Much less. And then other studies came out later, Mahmood, Dawson, Pooley, and they largely back this up, confirming worse outcomes if patients presented with symptoms first.
Okay, so the evidence kept building.
Right. And it probably didn't hurt that around this time and afterwards, less invasive endovascular techniques were starting to emerge and improve, which maybe made interventions seem a bit less daunting for some patients and doctors, too.
Right, the technology evolving alongside the clinical thinking. So after Shortell, the debate wasn't really if you should repair, but maybe which ones could potentially wait, or how best to repair.
Exactly. The conversation definitely evolved. Instead of, should we fix this asymptomatic one? It became more like, okay, are there any asymptomatic ones we don't need to fix right away?
Yeah.
And it turns out the natural history, how these things behave if left alone, it's pretty unpredictable. It's not quite like aortic aneurysms where size is such a dominant predictor of rupture.
How so? What's the main risk with popliteal ones, if not rupture?
It's usually thrombosis clotting up suddenly or embolization, where bits of clot break off and travel down the leg, blocking smaller arteries. And those events aren't always strictly related to how big the aneurysm is.
But size still comes into it, doesn't it? I feel like I hear about a 2-centimeter cutoff sometimes.
You do, yeah. 2 centimeters diameter is often used as a kind of threshold, a point where intervention is more strongly considered, even if there are no symptoms. But it's not absolute. It's still debated.
Why is that?
Well, because you see smaller ones cause trouble, and sometimes larger ones just sit there quietly for years. So size is a factor, but not the only one. The presence of clot lining the wall of the aneurysm mural thrombus, that's another factor people look at closely now.
Because that clot could break off.
Precisely. It's seen as a potential source for those emboli.
And you mentioned the less invasive treatments earlier. How much have they changed the calculation here?
Oh, significantly. Endovascular repair using stents and grafts inserted through catheters has become much more common.
Less physiological stress on the patient generally.
Generally, yes. Compared to traditional open surgery, it can be easier on the patient, especially older folks or those with other health issues. This lower threshold for intervention, technologically speaking, probably also pushes things towards fixing more aneurysms earlier.
Plus, we've gotten better at dealing with the emergencies when they do happen.
We have. Techniques for clot removal, thrombolysis, and mechanical thrombectomy have improved. So if someone does present with acute limb ischemia, our ability to salvage the limb is better than it was in the era Shortell was studying. That might subtly influence the risk-benefit calculation for observation in some very specific cases, but the preference is still strongly towards avoiding that scenario altogether.
So fast forward to today. If you diagnose someone with a popliteal artery aneurysm, What goes into the decision-making process now? Sounds much more personalized.
It really is much more tailored. That 1991 paper set a strong foundation. Elective repair is generally preferred, but now we layer on a lot more individual assessment.
Like what factors?
Well, size and thrombus, yes. But also the patient's age, how active they are, their overall surgical risk, do they have bad heart disease, lung disease, what's their BMI? If we're thinking open surgery, how good is their saphenous vein?
Right, the conduit.
Exactly. What's their runoff like downstream? Have they had any symptoms before, even minor ones, maybe related to emboli? And really importantly, what does the patient want after you've discussed all the options, the risks, the benefits?
Patient preference playing a bigger role.
As it should. It's a shared decision-making process, ideally.
Okay, so wrapping this up, it really feels like that 1991 Shortell paper was, well, truly a landmark. It drew a line in the sand.
I think that's fair to say. It was pivotal. It provided strong evidence that being proactive with popliteal aneurysms saved limbs compared to waiting for an emergency.
Right.
It fundamentally shifted the standard approach.
And it really set the stage for all the refinements and the integration of newer technologies that we've seen since.
Absolutely. It changed the core question and paved the way for the more nuanced, individualized, and technologically advanced care we aim for today.
So it leaves you wondering, doesn't it? With endovascular tools getting better all the time, and our understanding of risk factors getting sharper, what will managing these aneurysms look like in another 10 years? What new data, or maybe even, AI-driven risk calculators might fine-tune things even further? Definitely something to keep watching.
It is indeed. The evolution continues.
Thanks for taking this deep dive with us today. It was really insightful.
My pleasure. Great discussion.